Well, welcome. We're here with Associate Professor David Szmulewicz from Melbourne. And in this tutorial, we're going to be talking about dizziness and balance disorders. So, David, what are the symptoms of individuals who have balance disorders?
So these can vary, and the language that patients use to describe them can vary as well. But broadly speaking, people report dizziness, and that can be an internal sensation of movement or spinning, or what we refer to as vertigo, which is generally described as movement of one's world. And that's very often what we call rotatory, so like being on a merry-go-round. Some people will report imbalance, so there's not necessarily any sensation in the head of dizziness, but people feel that their balance is compromised, and this is usually when walking. So they'll say something like, I feel unsteady when I walk, and this might particularly be in the dark or on uneven ground. They might say that I tend to grab hold of rails when I'm climbing stairs. So they're the types of things we hear from people with balance disorders.
And are these symptoms acute in nature and sporadic in nature, or are they constantly present for the individual?
Yeah, so again, you get the whole continuum. The most common is episodes when it comes to dizziness. So people might, for instance, describe that when they lie back in bed, they see their ceiling spin for a period of 15 or 30 seconds, and then that abates. And that's what we call episodic vertigo, or more correctly, episodic positional vertigo, because the position brings it on. But when we talk more about imbalance and serious issues with walking or gait unsteadiness, then that's often chronic, and in some people that's progressive, so it does worsen over time.
So what causes these kinds of symptoms?
Yeah, sure. So broadly, we have three props of balance. So one is our inner ear balance mechanism, or the vestibular system. Two is sensation, so the messages coming from our feet and legs, which tells our brain where our body part is in space, which is important for movement. And three is a part of our brain called the cerebellum, which is involved in coordination and ensuring that our planned movement is the actual movement that we carry out. So if you like, an error detection system.
How do you go about assessing?
Yeah, so the first thing we do really is talk to the patient. So the symptoms are somewhat helpful. So getting back to an earlier example I gave, if a person is only having episodes of spinning of their visual world, and this happens when they adopt a certain position, that might be looking up or looking down, or the example I gave earlier of lying back in bed, then that will point us in a certain direction. And most often that points us towards the inner ear balance mechanism. People might describe the onset of dizziness, which has been accompanied by other features, such as headaches, blurring of vision, light and noise sensitivity. And this will point us towards a condition that involves the brain, but is not structurally serious, and that is vestibular migraine, which is the second most common cause of episodic vertigo. In this context, it's probably important to note that we do see a subset of patients with acquired brain injuries who suffer post-traumatic vestibular migraine, which can go on for months to years after the head trauma. And then if people describe problems which are referable to other components of the nervous system, such as speech and upper limb dexterity, then we'll be looking at the cerebellum or adjacent parts of the brain.
There's quite a couple of different ways of assessing individuals, and quite different really, aren't they? Different mechanisms going on there. So what are treatments? I would imagine they would be quite, similarly variable.
Yeah, absolutely. So in the first example I gave of the person who lies back and experiences their ceiling spinning, then the most likely cause of that is a condition with an abbreviation that's BPPV. I'll spare you the full name. And that's the most common cause of episodic vertigo. It can be caused by trauma, because what happens is small, dense crystals deep in the inner ear mechanism, which are normally housed in a jelly, become loose and travel into the balance canal where they cause havoc. And one of the reasons that they can become loose is because of head trauma, and we then call that post-traumatic BPPV. But the good news is that the treatment for that is usually a set of repositioning maneuvers which get the particles out of the canals and into a pouch where they no longer cause any difficulties. If we talk about vestibular migraine, then the treatment is medications. And if we talk about a cerebellar problem, then in general, there are not curative treatments, but there are certainly a range of management options that we can initiate.
Wow, so it sounds like with those various treatments, there'd be a handful of different clinicians who are involved in the treatment for these individuals. Who's involved?
Yeah, so that's right. Broadly speaking, neurologists and ENT surgeons. So amongst neurologists, it's usually neuro-otologists. So this is the intersection of the brain, neuro, and oto, the ear. And they will generally manage conditions involving any part of the neurological system. Then again, there are ENT surgeons who specialise in the inner ear balance mechanism, and they'll tend to concentrate on conditions affecting the vestibular apparatus, but will usually involve a neurologist if there's a brain component.
Right. The
other important clinicians to mention are physiotherapists, and they come in a couple of special flavours, and they are vestibular physiotherapists and neurological physiotherapists. And so we'll very often involve them in care.
Okay, so it's a quite a diverse group of experts involved in treatment, pending the accurate diagnosis. What are the prognoses for each of the different types of balance and dizziness disorders that you see?
Yeah, so for a condition such as BPPV, the prognosis is excellent. We know that once someone has had BPPV, there is an increased chance of a recurrence, but that is usually easy to treat. And once treated, we have an established means such as a vestibular physiotherapist who the patient can manage. For vestibular migraine or post-traumatic vestibular migraine, the treatment is medicines, and broadly those are acute treatments, so medicines to help abolish an episode, and preventers, which are taken if a person gets frequent attacks, and the idea is that these prevent the onset of attacks. With the more complex cerebellar conditions, these involve a range of management options and include quite a large allied health team, neurological physiotherapists, speech therapists because swallow can be affected, and occupational therapists.
Well, thank you very much. Thank you for your insight. Is there anything else that we need to know in terms of managing cases or claims involving balance and dizziness disorders?
Yeah, I think there's a couple of points here. One is that it's not an area that most doctors get much training in. So diagnoses are often very general and not particularly accurate. The other thing to say is that it's an area where it's not uncommon for there to be more than one diagnosis. So we might see a patient who's had a head injury, and they will suffer from both post-traumatic BPPV and post-traumatic vestibular migraine. And obviously the treatment is very different. So the diagnoses need to be made, the treatments need to be embarked on, And the important thing for the referrers is that the prognosis is very different. So there may be ongoing needs for management of vestibular migraine, while there may not be for the BPPV. The other situation which we see not uncommonly, and particularly in our brain injury patients, is that they may, as part of the actual brain injury, as opposed to the ear, which would be the site of post-traumatic BPPV, suffer with non-specific dizziness. Now, the non-specific dizziness tends to be constant and is an acknowledged component of acquired brain injuries, and can in fact be a particularly disabling component of an acquired brain injury patient's symptoms and require significant ongoing support.
Okay, thank you very much for that. So thank you for your time, David. Associate Professor David Szmulewicz can of course be booked through the MEDirect platform and does a wide range of medico-legal assessments ranging from general IMEs, workers' compensation matters, TAC matters, medical negligence, public liability and the like. So thank you very much for your time today.
Pleasure.